Okay, good afternoon, all of you. I hope I am visible and audible to you all. In the chat box, if you can please tell me if I am audible and visible to you all. Just show me a thumbs up, please. Om Sai Ram Abhinandan. Just let me know if I am audible and visible. Great. Now, the other day when I was taking your OBS images session, there was some problem in the connection and the connection broke, and we were discussing vacuum at that time, right? So we were discussing this question and the connection got lost. So before I take up gynae with you, these last few images of OBS which were left in the previous session, first I'll do that and then we'll go to the gynae images, right? So I'll just start from the very beginning, that I was discussing this question with you, that all of the following are contraindications for use of the instrument shown in image except. Now this was a question which came in neetpg as well, and it also came in in January 2023 fmge exam. Exactly the same question came in January 2023 exam. So over here you have to look at these two words that they are asking you. All of the following are contraindications for the image, for the instrument which is shown in the image except, right? Now this image, you know that this is a vacuum cup, and a vacuum, whether it's a vacuum or whether it is instrumental delivery, for all these cases, for all the instruments, whether vacuum or whether it's forceps, the contraindications are cephalopelvic disproportion. Cephalopelvic disproportion could be written in the form of macrosomia, then inadequate pelvis, known bony deformities in the baby, for example, osteogenesis imperfecta, known coagulopathy in the fetus, and a relative indication is if mother is HIV positive. So over here, the option CPD will be a contraindication whether they are asking about vacuum or whether they are asking about forceps. Now, conditions which are contraindications only for the use of vacuum. Vacuum is contraindicated in preterm deliveries, in phase presentation, in breech presentation, and in intrauterine death. In phase presentation, it is contraindicated because if you use a vacuum, that can increase the chances of intracranial hemorrhage. In phase presentation and buttocks, in breech. So in phase presentation, obviously you're not going to apply the vacuum cup over phase, and in after coming head of breech, there is no space for the vacuum to be applied. In case of IUD, the pressure will not be generated, and so you will not be able to apply a vacuum. Now, although these four are contraindications for vacuum, but they are not contraindications for forceps. In preterm delivery, in phase, in breech, and in IUD, you can apply forceps, right? So this means that in phase, yes, vacuum is contraindicated. In preterm, vacuum is contraindicated. But fetal distress is an indication for doing instrumental delivery. So indications for instrumental delivery are: number 1, fetal distress; number 2, prolonged second stage of labor; number 3, if you want to cut short the second stage of labor. For example, your patient is a heart disease patient or she has PIH and you want to cut short the second stage of labor, then you use instrumental delivery. Earlier, it was said that vacuum is not appropriate for fetal distress. This is because it takes time to build that much of pressure. Now, the pressure which is needed by vacuum, or the pressure which is generated by vacuum, the best answer is 600 millimeters of mercury or 0.8 kg per centimeter square. Now, in order to build up this much pressure, you need time. That is why earlier it was said that vacuum is not preferred in case of fetal distress. But now the vacuums which are available to you, they can generate this much of pressure within minutes. And because vacuum is much easier to use than a forceps, that is why nowadays vacuum is being preferred in comparison to forceps for fetal distress, clinically basically, right? The other very important thing is, where do you apply a vacuum? This image is showing you flexion point. This is the place where if you apply a vacuum, the center of the cup is going to should come on this place. Now when we say center of the cup should come on this place, this means that this point is flexion point, and this flexion point is 3 centimeters anterior to the posterior fontanelle, and it is 6 centimeters posterior to the anterior fontanelle. Right? So it is 3 centimeters anterior to the posterior fontanelle and 6 centimeters posterior to the anterior fontanelle. And where should the cup come? The cup's midpoint of the cup should come on flexion point. Now a vacuum cup is generally 6 centimeters in diameter. Right? So if it is 6 centimeters in diameter, this means that the rim of the cup is going to lie at the posterior fontanelle, and the rim of the cup will be 3 centimeters posterior to the anterior fontanelle. So once in your PGI questions, when inicet was not there and it was PGI, in PGI exam this question was asked that the periphery of the cup is 3 centimeters from the internal os or 6 centimeters from the internal os, or it is at the level of, anterior fontanelle, not internal os, I'm so sorry. The periphery of the cup is 3 centimeters from anterior fontanelle or 6 centimeters from anterior fontanelle, or it is at the anterior fontanelle. So remember that the periphery of the cup is going to be 3 centimeters away from the anterior fontanelle, and it is going to lie on the posterior fontanelle, right? Clear to all of you? Yes? अब हिंदी में कैसे पढ़ा दो? Half of you are not going to understand जब मैं हिंदी में पढ़ाऊंगी. So, and questions are going to come in English. So you will have to start learning to understand English, and I am not speaking anything which is not understandable. This is plain simple English, and my accent is also a very desi accent, right? So I'm sure you will all understand my English. Okay. Now, all of the following are prerequisites for applying the forceps, which is shown in the image. Now, in this image, what you are seeing? In this image, you are seeing a forceps which is short, right? So, this is an outlet forceps or Wrigley's forceps. Whenever you get a short, stout forceps, then that's a Wrigley's forceps, which is an outlet forceps, right? Now, what are the requirements for outlet forceps? The requirements for outlet forceps are: the head should be on the perineum, scalp should be visible at the perineum. So head should be on the perineum and scalp should be visible at the perineum. Skull should be on the pelvic floor, right? So head should be on the perineum, scalp should be easily visible on the perineum. Clinically हम क्या कहते हैं? Clinically we say that if you can see the baby's hair without separating the labia, that means you have to apply outlet forceps. Criteria ये कहता है, head should be on the perineum, skull should be visible at the perineum, then the scalp should be visible on the perineum, skull should be on pelvic floor, and sagittal suture should be in AP diameter. I am sure all of you remember this, that forceps cannot rotate the head of the baby. That is why अगर हमें forceps apply करना है, if we want to apply the forceps, the sagittal suture should be in AP diameter, right? Max to max, maximum deflection जो मिल सकता है, maximum it can be deflected to 45 degrees. अब यहाँ पे they are saying sagittal suture should be in transverse diameter of the pelvis. That's wrong, right? So all of the following are prerequisites except, this is an except question. So yes, head should be on perineum, scalp should be visible at the perineum, membranes should be ruptured. Whenever you are applying any instrument, membranes should be ruptured, right? आउटलेट फॉर्सेप्स का जो क्राइटेरिया होता है वो स्पेसिफिक होता है. कुछ क्राइटेरिया होते हैं विच आर एप्लीकेबल टू एनी काइंड ऑफ फॉर्सेप्स एप्लीकेशन. दोज क्राइटेरियाज आर दैट पेशेंट शुड बी फुल्ली डायलेटेड, राइट? हेड शुड बी रोटेटेड. Head should be rotated. When we say head should be rotated, it means that the sagittal suture should be in AP diameter, right? Then station of fetal head, it should be more than equal to +2. Membranes should be ruptured. Bladder should be empty. Bladder of the patient should be empty. Uterus should be contracting. You should have taken a consent. Consent is very important for instrumental deliveries, right? And there should be no CPD and no inadequate pelvis. It should not be a case of CPD or inadequate pelvis. This is a general requirement for all kinds of forceps deliveries, right? These three, 1, 2, and this skull should be on the pelvic floor. These are specific requirements for outlet forceps. Clear to all of you? Yes? Now, as I told you, these days we are going to apply forceps only when the station is +2 or below that. So when you are applying forceps when the station is +2 or below that, that is called as low forceps application. That's a low forceps application, right? Now comes a few images which are related to the inlet, right? And they ask you in this kind of inlet is seen in which pelvis, and exactly this question was asked in FMG January 2023 session where they had shown a round inlet. So approximately a round inlet is seen in case of gynecoid pelvis. In a gynecoid pelvis, the transverse diameter is more than AP diameter, but then roughly you are getting a round or a transverse oval inlet. But if you are getting a round, it has to be a gynecoid pelvis, right? Then comes over here the B image. B image is of B image is of anthropoid pelvis. Anthropoid pelvis. How do you recognize an anthropoid pelvis? Anthropoid pelvis is the only pelvis in which AP diameter is more than transverse diameter. So this is the only pelvis where AP diameter is more than transverse diameter. So the shape of the inlet is an antero-posterior oval, right? This is the pelvis where you get face to pubes delivery. If they ask you face to pubes delivery seen in, it is seen in anthropoid pelvis. If they ask you direct occipito-posterior position or persistent occipito-posterior position. Direct occipito-posterior position or persistent occipito-posterior position is seen in which pelvis? It is seen in anthropoid pelvis, right? The most common pelvis is gynecoid pelvis, followed by anthropoid pelvis, and then we have android pelvis. So image C shows you android pelvis. In android pelvis, the shape of the inlet is heart-shaped. It has got convergent side walls, right? This is the only pelvis where you get prominent ischial spines, and because it is heart shaped, so the posterior segment is broader than the anterior segment. So you have a narrow anterior segment. And when we are talking about subpubic angle, in a male pelvis, that is an android pelvis, subpubic angle is acute, whereas in a female pelvis, it is obtuse, right? So if they want to ask you about android pelvis, these are the things which they are going to base their questions on. Please also remember, if they ask you occipito-posterior position, just occipito-posterior, they are not adding the prefix persistent, they are not adding the prefix direct occipito-posterior. It's simply, if they ask you occipito-posterior position is common in, it is common in android pelvis. It is common in android pelvis, right? Then comes the image of the fourth pelvis, that is the D image which is seen here. What I am seeing over here is a pelvis where transverse diameter is much more than AP diameter. So if transverse diameter is much more than AP diameter, that is what is a platyploid pelvis. In a platyploid pelvis is a shallow pelvis. In a platyploid pelvis, the shape of the inlet is going to be flat or bowl shaped, katora shaped, right? It's a bowl shaped inlet or a flat inlet. It's a flat pelvis. The other thing which you have to remember is, if they ask you face presentation is most common in which pelvis? Face presentation is most common in platyploid pelvis, but face to pubes delivery is seen in which pelvis? Then that's anthropoid pelvis. Face to pubes delivery is different and face presentation is different. So face presentation is seen in platyploid pelvis. Face to pubes delivery is seen in case of anthropoid pelvis. In a platyploid pelvis, definitely you are going to have divergent side walls. Convergent side walls were seen in android pelvis. Divergent side walls are seen in platyploid pelvis. The only pelvis where ischial spines are prominent is android pelvis. This is the reason why, if they ask you deep transverse arrest is most common in which pelvis? Deep transverse arrest is most common in android pelvis. Clear to all of you? Yes. Now quickly you have to look at the images of the Leopold's maneuvers being performed. They are very frequently asked images in your exam. So Leopold's first maneuver. First menu. First, you are writing in the chat box and I'm getting distracted. So the Leopold's first maneuver, what is it called as? It is called as the Fundal Grip. This is called as the Fundal Grip, right? Now this fundal grip, what are the things which Leopold's first maneuver is going to tell you? It will tell you about the lie of the baby, because if fundal grip is absent, if fundal grip is empty, not absent, if fundal grip is empty, then that means it's a case of transverse lie, right? Then it also tells you about presentation. Most of the time when you are going to do a fundal grip, you are going to get a broad, soft structure. You will feel a broad, soft structure. If you are feeling a broad, soft structure at the fundus, this means it is the buttocks which you are feeling, and this means it's a case of cephalic presentation, right? So your first grip tells you about, the fundal grip tells you about the lie and the presentation of the fetus. Then comes the second Leopold maneuver. So now from the fundus, you will bring your hands over to the side of the mother, right? That is why this is called as lateral grip. This is also called as the umbilical grip, right? Now, lateral grip or umbilical grip, it tells you about the position of the fetus. It tells you about the position of the fetus. Wherever you are feeling the back of the fetus, wherever you are feeling the back of the fetus, so if the back of the fetus is felt on which side, you have to see that. Back means that on one back will be felt like a board-like continuous structure. So if a board-like continuous structure is felt on left side, so suppose it is felt on left side, that means the position is LOT, LOA or LOP. If the board-like continuous structure, that is the back, is felt on right side, then the position of the baby is ROT, ROA or ROP. On one side, you will feel the back of the baby. On the other side, you will feel multiple knob-like structures. Multiple knob-like structures. And these multiple knob-like structures are the fetal limbs. Clear? Then you are going to do the Leopold's third maneuver. Now in Leopold's third maneuver, so just let me show you an image of Leopold's third maneuver being done. Now in Leopold's third maneuver, from the side you are going to bring the hand of your hands to the pelvic area. So now you have to bring your hands to the pelvic area. Just let me get a better image of Leopold's third maneuver. See. So now you are bringing your hands to the side. Now you are going to use only one hand. Just let me get these images. Okay. Now see. Now what you are going to do? Now you are going to use your one hand. At that one hand you are going to bring at the pelvic area. This is Leopold third maneuver. This is Leopold's third maneuver. Leopold's third maneuver is also called as the Pelvic Grip. Please, this is a very, very important image. You have to note over here that only one hand is being used. only one hand is being used. Also, you have to remember that the first, second and third maneuver, they are done while you face the face of the patient. While facing the face of the patient. While facing the face of the patient. Leopold's third maneuver is going to tell you again about the presentation of the baby. Because if you are feeling a globular, hard, firm structure, it means it is the head which you are feeling, right? That means it is cephalic presentation. Also, you are going to move the head or whatever presenting part you are feeling from side to side. That is, you are going to check the ballotability. Now, if you can move the part from side to side, this means just now the head of the baby has not entered into the pelvis. If you cannot move the head of the baby from side to side, it means the head is fixed, right? So, if ballotability is present, it means head is not fixed. And if ballotability is absent, it means head is fixed. Now what you are going to do for the fourth maneuver? For the fourth maneuver, you are going to face the feet of the patient. Face the feet of the patient, and this is done using both hands. This is done using both hands, and this is called as the deep pelvic grip. The deep pelvic grip. Again, please remember that Leopold's fourth maneuver again is going to tell you about the presentation. It will tell you about ballotability, and it will also tell you about the attitude of the fetus. So, three things you come to know through this deep pelvic grip: the presentation, the ballotability, and the attitude of the baby, right? Now, for the Leopold's fourth maneuver or the deep pelvic grip, you are going to take both your hands, you are going to keep it parallel to the patient's inguinal ligament, and you will try to reach below the head of the baby. If your fingers can reach below the head of the baby and your fingers converge, that means the head has not entered into the pelvis. But if your fingers cannot reach below the head of the baby and instead of converging, your fingers are diverging, right? Then that means the head has entered into the pelvis. So again, it tells you whether the head has entered into the pelvis or not. So it confirms the findings of Leopold's third maneuver. So it tells you about presentation, it tells you about whether the head is fixed or not, and it also tells you about the attitude of the baby, right? Clear to all of you? Sunny Ficao. Don't remember it anything as the first pelvic grip or the second pelvic grip. These terminologies are no longer used because some textbooks said Leopold's third was the first pelvic grip and some said Leopold's fourth was the first pelvic grip. So you don't have to go into that trap. You simply have to remember Leopold's third is polyg grip and Leopold's fourth is deep pelvic grip. Clear? Don't remember anything as first or second pelvic grip, right? So this is what all you have to remember about the OBGY images. In the OBS images I have discussed separately with you. These few images were left. Now let me come to the gynae images. So in gynae, this over here is image of endometrial biopsy. Now this can be asked as a clinical question. They can say that there is a female who underwent endometrial biopsy. She complains of infertility and you have to tell that in which phase do you get such an image, or you have to tell whether ovulation has happened in her or not. please remember that if you are getting simple tubular glands like these are simple tubular glands. If you are getting simple tubular glands and in these glands you are seeing that the nuclei are at different levels, this is what is called as pseudostratification. This means that this is an image from proliferative phase. That means suppose a female has come to you with infertility and you have done endometrial biopsy in the premenstrual phase. Now in the premenstrual phase you were expecting proliferative changes. अब यहाँ पे instead of proliferative changes you were expecting secretory changes. In the premenstrual phase you were expecting secretory changes, but instead of secretory changes what you are getting are proliferative changes. इसका मतलब that in this female as of now also the predominant hormone is estrogen, right? Because proliferative endometrium occurs with estrogen. This means that this female has not ovulated, right? So either this can be asked in the form of image-based question or it can be converted into a clinical question. Clear to all of you? So remember, proliferative phase में कैसे मिलते हैं glands? Glands are simple and tubular and the nuclei will be at different levels. That is what is pseudostratification. Now look at this image over here. What are you seeing in this image? In this image you are seeing कि glands अब coil करने start हो गए हैं. The glands have started coiling. The most characteristic thing what I am seeing over here is that all the nuclei, they are being pushed to one side because below every nucleus is a vacuole. कोई भी न्यूक्लियस देख लो, हर पर्पल कलर्ड न्यूक्लियस के नीचे हमें वैक्यूल दिखेगा. You pick up any nucleus, you will get a white colored vacuole below that nucleus. This is called as subnuclear vacuolation. अब अगर ये क्वेश्चन पूछा जाए कि सब न्यूक्लियर वैक्यूलेशन कब मिलता है, तो प्लीज रिमेंबर दैट ऑल्दो वी से दैट सब न्यूक्लियर वैक्यूलेशन इज अर्लीस्ट साइन ऑफ ओव्यूलेशन ऑन एंडोमेट्रियल बायोप्सी, but it is seen at day 17 of the cycle. So agar this image is given to you and they ask you this particular image is seen in, and the options given to you are proliferative phase, at the time of ovulation, in early secretory phase, and in late secretory phase. So option A is proliferative phase, option B at the time of ovulation, option C early secretory phase, option D late secretory phase. What are you going to mark the answer as? A, B, C or D? I am waiting for your answers in the chat box. What will you mark the answer as? A, B, C or D? So I have started getting your answers. Some of you are saying B, some of you are saying C. Some are also saying D. Remember, although as I told you, subnuclear vacuolation is the earliest sign of ovulation on endometrial biopsy, but it is seen on day 17 of the cycle, and day 17 of the cycle का मतलब है early secretory phase. So this is an endometrium biopsy in early secretory phase. Best answer is early secretory phase. If early secretory phase is not given in the options, right? So suppose early secretory phase ना दिया होता option में and ये दे दिया होता menstruation. proliferative phase, ovulation, menstruation, and late secretory phase, then my answer would have been at the time of ovulation. So at the time of ovulation is the second best answer. Best answer is that this kind of image, subnuclear vacuolation, you get in early secretory phase. Second best answer is ovulation. Clear to all of you? Yes? अब सी नहीं होगा बच्चों आंसर. अब तो मैंने menstruation डाल दिया वहां पे. Menstruation is never the answer. Either the answer is early secretory phase, which is the best answer. वो नहीं दिया है, then ovulation is the second best answer. Right? Now, how do you get endometrial biopsy in the late secretory phase? In late secretory phase, the endometrial biopsy is going to show you an image like this. What is this image showing you? This image is showing you hypercoiling of glands, and inside the glands, can you see these glands are hypercoiled? So you are getting hypercoiled glands. And inside the glands, I am seeing this white color substance, which is actually the secretions. So in late secretory phase, you get corkscrew or sawtooth appearance of the glands. And there are secretions which are present inside the glands. Secretions are present inside the glands, right? So this endometrial biopsy is seen in late secretory phase. Clear? Corkscrew or sawtooth appearance, very good. Now, if they show you an image like this, where between two slides, the cervical mucus is being stretched, this property is called as spin barkite, right? Spin barkite again is seen under the influence of estrogen, and it is seen in the proliferative phase. So spin barkite, that means the cervical mucus can be stretched. This elastic property of cervical mucus is spin barkite, and this is seen under the effect of estrogen in proliferative phase, right? This over here is the fern-like appearance of cervical mucus, and this is called as ferning. Now, this ferning indicates again proliferative phase. This ferning is not only due to the presence of estrogen, but also because of sodium and chloride. Another important point about ferning is that ferning appears by day 8 and it disappears by day 18 of the cycle. So, ferning is under the effect of estrogen. जैसे ही प्रोजेस्ट्रॉन आता है, ferning disappears. So ferning appears by day 8 and it disappears by day 18 of the cycle. अगर ferning gynae के क्वेश्चन में दिखाई जाएगी, then that means it is the ferning which is seen in cervical mucus under the effect of estrogen. अगर ferning दिखाई जाएगी OBS के क्वेश्चंस में, so in OBS, please remember, there is something which is called as the Fern test. And this Fern test indicates that a female has had premature rupture of membranes, and this ferning is due to the presence of amniotic fluid, right? तो gynae में ferning मिलती है cervical mucus में under the effect of estrogen. OBS में ferning मिलती है because of amniotic fluid, in other words due to premature rupture of membranes. Amniotic fluid ferning is thin and cervical mucus ferning is thick. But that is not very important. Simply you have to remember Fern test is used in OBS for premature rupture of membranes, right? Then these three cells, they are very, very important for you. If you are getting pink colored cells, in other words, eosinophilic cells with a pycnotic nucleus. This means it is superficial cell. Please remember, superficial cells are seen whenever there is estrogen predominance. In other words, in the first half of menstrual cycle, the cell which is going to predominate in the vaginal epithelium will be superficial cells. Then comes this blue colored cell, which is acidophilic cell. Again, this has a pycnotic nucleus. This has a small nucleus, but the nucleus is larger in comparison to the superficial cells, and it has got very distinct margins. The cell has very distinct boundaries, right? This is intermediate cell. The other name for intermediate cells are navicular cells. These kinds of cells, they predominate whenever there is progesterone predominance. जब भी body में progesterone ज़्यादा होगा, then it is these blue color cells which are going to predominate, right? And progesterone is more in the second half of the cycle. Then comes these third types of cells, which are again blue colored cells, but they have a very large nucleus in comparison to others, and they have blurred margins. This is what is a parabasal cell looks like. So A was superficial cell, B was intermediate cell, and this C is parabasal cells. Parabasal cells, they predominate whenever there is no hormonal influence, right? Now, what we do is we count 100 vaginal epithelial cells, and out of those 100 cells, we see how many are parabasal, how many are intermediate, and how many are superficial. This is what is called as maturation index. Maturation index, the first number in maturation index is the number of parabasal cells. Second number is the number of intermediate cells. And third number is the number of superficial cells. So instead of pus, it is pis, right? First number is parabasal, then intermediate, and then superficial. It is not the number which is important. It is the relative ratio which is important. So for example, if your question says that maturation index is 0:30:70, this kind of maturation index is seen in which condition? 0:30:70. Tell me in the chat box. Zero is to 30 is to 70. What does this mean? That how many cells are parabasal cells? 0. How many cells are intermediate? 30. How many cells are superficial? 70. It means superficial cells are more than intermediate cells. This means there is estrogen predominance, and that means this is proliferative phase. Right? If the maturation index comes as 0:70:30, then this means it is the intermediate cells which are predominating. So this is secretory phase maturation index, right? And if the number is 100:0:0, that means parabasal cells are predominating, which means there is no hormonal predominance, and this is seen after menopause, or this is seen in females during puerperium, right? So during menopause and puerperium, the maturation index could become 100:0:0. Clear to all of you? Yes. Now, look at this ultrasound image over here. In this ultrasound image, what are you seeing? In this ultrasound image, you are seeing that endometrium is appearing triple layered. There are 3 layers of endometrium which can be so clearly made out. I am raising so that you can make it out. This is trilaminar or triple layered endometrium, and this is seen in late proliferative phase. Best answer is, if they show you this ultrasound and they ask you this trilaminar endometrial is seen in which phase, it is seen in late proliferative phase. That's the best answer. अगर late proliferative phase answer में नहीं दिया होगा, then you are going to say at the time of ovulation, right? The best answer will be late proliferative phase. Compare this appearance of endometrium to the appearance of endometrium in this image. In this ultrasound, the endometrium is appearing thick, right? So there is a thick echogenic endometrium. Thick echogenic endometrium hai, and you are getting a posterior acoustic enhancement. So whenever you are getting thick echogenic endometrium and posterior acoustic enhancement, that is a marker of secretory phase of the endometrium, right? So triple layered endometrium ko do not say the best answer is at the time of ovulation. All of you are saying it incorrectly. Triple layered ka best answer is late proliferative phase. If late proliferative phase is not given in the options, then you are going to say at the time of ovulation, right? And this over here, that is a thick echogenic endometrium with a posterior acoustic enhancement. This is seen in secretory phase under the influence of progesterone. Very good. Now, this procedure, what is being done? This is a colposcopy being done, right? Now, colposcopy is an OPD procedure. What is the magnification of colposcopy? It magnifies to 30 times. Which filter, which color filter do you use in colposcopy? Now, when you are doing colposcopy, you switch on the green light or the green filter, because with the help of this green filter, you will be able to identify the abnormal blood vessels in a better manner, right? Then you are going to apply 3 to 5% acetic acid, and you are going to take biopsy from aceto white areas, right? Wherever there are white areas, you are going to take biopsy from those areas. Please remember, colposcope se you cannot visualize the endocervix, right? Now suppose they show you an image. अच्छा, now who is going to tell me कि ये abnormal blood vessels कौन से मिल सकते हैं? What are the abnormal blood vessels which you can get in colposcopy? What are the abnormal blood vessels? You can get mosaic blood vessels. You can get punctate blood vessels, or you can get reticular blood vessels, right? Now, the next image is, what you are seeing over here is that cervix, and in cervix you are getting some white areas and some pink areas. These white areas are called as aceto white areas. And when I told you that when you are doing colposcopy, you apply 3 to 5% acetic acid, and from aceto white area you have to take the biopsy. So these are the areas from where you have to take the biopsy. Please remember, same is the principle with VIA. In VIA, it's the same thing. In VIA also you apply 3 to 5% acetic acid, and you take biopsy from the white areas, right? So if someone asks you which is the most cost-effective method of cancer cervix screening, the most cost-effective method for cancer cervix screening is VIA. Clear to all of you? Yes? Now, Coming to the next image. In the next image, what you are seeing, what is this? This over here is Ayer's spatula. And this is how you perform a pap smear. In pap smear, you use two instruments, Ayer's spatula and you are using endocervical brush. With the help of Ayer's spatula, you are going to take the sample from transformation zone, right? So this bifid end of the Ayer's spatula, it fits into the transformation zone, and then you are going to rotate this Ayer's spatula by 360 degrees twice or thrice, and whatever material comes, you are going to put it on one slide, right? Then you are going to take this endocervical brush. So if they show you this image again, this is that of endocervical brush. With the help of endocervical brush, you take specimen from endocervix and you roll it on the same slide where you had put the sample with the help of Ayer's spatula. So it's just one slide which you are preparing in pap smear. Please remember that this slide should not be air dried, and the fixative which you use in pap smear is 95% ethyl alcohol plus minus 5% ether, right? Clear to all of you? Now, a very important update which I want to share with all of you. All the Marrow subscribers, you already know this. If you are not a Marrow subscriber, then please note this update. There are certain obscuring factors for pap smear. The obscuring factors for pap smear are blood and air artifacts. And there are certain interfering substances with pap smear. The interfering substances when you do a pap smear are vaginal lubricants and semen, right? तो ये जो interfere करते हैं with pap smear, they should never be present. Obscuring factors, if they are present and they are affecting a slide more than 75%, then we say that the sample was inadequate. But if it is present in a small amount, that is okay. Right? That is why bleeding is not an absolute contraindication for pap smear. Bleeding is a relative contraindication for pap smear. The interfering substances with pap smear, as I told you, are semen and vaginal lubricants. That is why before you do pap smear, you have to instruct the patient that whenever she is coming for pap smear, she should not be using any vaginal lubricants and there should not be any intercourse for 48 hours before the pap smear, right? So for 48 hours before pap smear, there shouldn't be any intercourse, there shouldn't be use of any vaginal lubricants. According to the Bethesda classification, so this is according to Bethesda classification, adequate sample means if in a conventional pap smear you are getting 8,000 to 12,000 squamous cells per 10 high power fields, or if you are getting 10 to 12 endocervical cells. This is for conventional pap smear. Conventional pap smear को adequate तब कहते हैं when you are getting 8,000 to 12,000 squamous cells per 10 high power field, or you are getting 10 to 2 and you are getting 10 to 12 endocervical cells. Instead of conventional pap smear, you may do a liquid based cytology. In a liquid based cytology, you use a single instrument, that is cervical broom or a cervical brush. As you can see over here, this cervical broom or cervical brush has bristles which are small also and which are long also. So these small bristles are going to take sample from the transformation zone and the longer ones are going to go inside and they are going to take the sample from the endocervix. right? So one difference between conventional PAP and liquid-based cytology is that here two instruments are not needed. You are needing only one instrument, and this is most commonly used cervical brush. Number two, you are not going to make any slide directly. This sample which you are bringing, you are going to put it in a fixative, and most of the times the fixative is methanol instead of ethyl alcohol, right? So here the fixative generally is methanol. Now, you are going to call liquid-based cytology or liquid-based PAP adequate if you are getting 5,000 squamous cells per 10 high power field and you are getting 10 to 12 endocervical cells, right? So conventional ke liye you needed 8,000 to 12,000 cells plus 10 to 12 endocervical cells. For liquid based, you need 5,000 squamous cells per 10 high power field and 10 to 12 cells, right? Now, when you are doing pap smear, sometimes while you are doing pap smear, there are certain infective organisms which you may accidentally discover when you did a pap smear. Infections के लिए कभी भी हम pap smear नहीं करते, but they are certain accidental findings which you may get on a pap smear, right? So over here, compare this cell with the cell which I showed you just now, the intermediate cell which I showed you just now. The intermediate cell which I showed you just now was so neat and clean, right? Now this cell which I am showing you, it is blue in color. It is like an intermediate cell, but it is not a very clear cell. What is appearing is that as if a lot of bacteria are adhered to this cell. And this is what is called as, now who's going to tell me what is this called as? I'm waiting for your answers. What is this type of cell called as? This is not called as bacterial. What is this called as? This particular cell is called as clue cell. Excellent. Right? And a clue cell is seen in case of bacterial vaginosis. Come to this image B. In image B, isn't it appearing as if there is a cotton plug, right? Which is blue in color and it is kept there. So this cotton wool appearance, this is what is called as cotton wool appearance, and this is seen with actinomyces. And I hope all of you remember that the most common vaginitis, the most common PID which you get in IUCD users is actinomyces, right? Okay, then look at these organisms which I have marked with red arrow. Look at these organisms and tell me, what do you think is the infection which you can see on this slide? What are you seeing over here? What are you seeing over here in this image? In this image, you have to concentrate on the arrow which I have marked, not on any other thing. I want you to concentrate on the arrow which has been marked. Now these small organisms, they are small organisms. They are even smaller than the nuclei of the vaginal epithelial cells, right? So these are small organisms which are smaller than the nuclei of the epithelial cells. These are the spores, and this is seen in candidiasis, right? So if you are getting small organisms, they are pointing towards small organisms which are smaller than the nuclei of the epithelial cells, that means that is candidal spores, right? So these are the candidal spores, right? Now look at this organism over here, which is marked by the arrow. This is a pear-shaped organism. Can you see a flagella also over here? This is what is your trichomonas. Trichomonas. This is a very typical appearance of trichomonas, where a flagella is also being seen, but you may get an appearance like this. Arrows are pointing towards a structure, and that structure is bigger than the nuclei. Now you cannot call it as candidal spores. This has to be trichomonas. So if it is smaller than the nuclei, that's a candidal spore. If it is bigger than the nuclei, that is trichomonas. Trichomonas you may see the flagella, you may not see the flagella, right? That is how you are going to recognize which infection is seen on pap smear, right? So these are small tricks which are going to help you in identifying. Now tell me, what is this arrow showing over here? In this image, what you are seeing? In this image, you are seeing that around the nucleus, there is a clear area, right? So there is perinuclear halo, right? And this perinuclear halo, where is it seen? It is seen in case of coilocytes. That is HPV infection, right? So you are getting perinuclear halo, and that indicates coilocytes. This is another image showing coilocytes, where the nucleus has been pushed to one side and rest everywhere you are seeing a vacuole, right? So this is coilocytes or coilocytosis. Clear? Now look here. What procedure is being done over here? And this coilocytosis or coilocytes is due to HPV infection, right? Very good, all of you. Now tell me, what procedure is being done in this image? What procedure is being done? Tell. What procedure is this procedure? Anyone in the chat box who's going to answer this for me? Excellent, Harideep. This is LLETZ, or this is LEAP. LEAP is done by an instrument which has got a thin wire from where you are going to pass the current. It is going to cut and coagulate at the same time. So here you are cutting the transformation zone in the form of a loop. So it is large loop excision of transformation zone, or it is LEEP. Now all those who are answering this as conization, अगर conization होता तो a cone shaped area would have been shown to be cut, right? In conization you cut a cone shaped area of the cervix. This is LEEP or LLETZ. Please remember that the treatment of choice or the management of choice for CIN2 and CIN3 at any age and at any parity is LEAP. At any age, at any parity, the treatment of choice for CIN2 and CIN3 is LEAP or LLETZ, right? Now this over here is classification, FIGO classification of fibroid. I don't want you to remember the entire classification, but I want you to remember that type 0, type 1 and type 2 are varieties of submucous fibroid. As you can see over here, type 0 means that the entire submucous fibroid is inside the uterine cavity. Type 1 means more than 50% is inside the cavity. Type 2 means more than 50% is inside the myometrium, right? So type 0, type 1 and type 2. Type 0 and type 1 can be removed hysteroscopically. Type 2 cannot be removed hysteroscopically, right? So type 0 and type 1, they can be removed hysteroscopically. Type 2 cannot be removed hysteroscopically. Clear? Now, few specimen images are very, very important, and one of the specimen which is very important is a fibroid specimen. So you should be very well aware with how a fibroid specimen looks like, how a polyps specimen look like, and how an adenomyosis specimen looks like. Now, over here I have written the keywords with the help of which you are going to differentiate a fibroid from a polyp. A fibroid will be white or off-white in color, resembling the myometrium. The cut surface of the fibroid gives a whorled appearance or a rough appearance or an uneven appearance. A fibroid is going to have a broad base, and a fibroid is surrounded by a pseudocapsule, right? And the blood vessels which supply the fibroid, they lie in this pseudocapsule. So if someone asks you which is the least vascular part of the fibroid, you are going to say the least vascular part of the fibroid is center of the fibroid, and that is why degenerations appear from the center of the fibroid. Fibroid समझ में आ गया? It will have a whorled appearance or a rough appearance. It will be white in color. Its base will be broad, and it will be surrounded by a pseudocapsule. The blood vessels which supply the capsule will be present in this pseudocapsule. Now compare a fibroid with the image of a polyp. A polyp is mucosal outgrowth, so it is pink, it is fleshy, right? It will be pink and fleshy. Jabki fibroid is white in color, right? A polyp will be very smooth. Whereas fibroid, just now I told you that a fibroid's cut appearance or cut surface will always be irregular, or it is going to be whorled, right? And a polyp hangs from a narrow base, whereas a fibroid arises from a broad base. Clear? So they may give you this. Now, iske basis pe, I am going to show you certain ultrasound images, and you will have to identify that whether it's a polyp or a fibroid. I'm also going to show you hysteroscopic images, and you are going to tell me whether it's a fibroid or a polyp. So all these words which we are writing to describe a fibroid or a polyp are important in recognizing a fibroid or a polyp on hysteroscopy, right? Now, this is a very, very typical image which they give you. So over here, image C is showing you a globular, symmetrically enlarged uterus. अब tell me, कभी भी fibroid में can you get a symmetrically enlarged uterus? नो, बिकॉज फाइब्रॉइड किसी एक साइड से अराइज करेगा, right? So in case of fibroid, you never get a globular symmetrically enlarged uterus. If you are getting a globular symmetrically enlarged uterus, it means it's an adenomyosis. In adenomyosis, a very typical feature is adenomyosis means that endometrium is present inside the myometrium. So, ye endometrial glands are going to bleed at the time of menstruation. So, when you are going to see the cut surface of adenomyosis, you are going to see hemorrhages. Do you see so many hemorrhages over here? Red spots. These are all hemorrhages. So these are because of the presence of endometrium inside the myometrium, right? What is the most common age group for adenomyosis? Adenomyosis के लिए most common age group is reproductive age, but then a little late reproductive age around 40 to 45 years. In a case of adenomyosis, the chief complaint of the patient is going to be menorrhagia and dysmenorrhea. If you have to choose between menorrhagia and dysmenorrhea, then the most common presentation should be chosen as menorrhagia and not dysmenorrhea. Dysmenorrhea should be chosen for endometriosis. Endometriosis की chief complaint is dysmenorrhea, right? Fibroid की chief complaint is menorrhagia. Polyp की chief complaint is metrorrhagia, that is irregular bleeding. Adenomyosis की chief complaint is menorrhagia and dysmenorrhea. But if I have to choose between the two, you should choose menorrhagia as the answer, right? Now, what is the management of fibroid? Management of adenomyosis. Management of adenomyosis is hysterectomy. Clear? Now, these are some hysteroscopic views. And based on these views, based on the characteristic, you will have to tell whether it's a fibroid or whether it is a polyp. So look at image A. Image A में हमें जो structure दिख रहा है, it is very irregular from outside. It is pale and it is arising from a broad base, and I am seeing surface blood vessels. And as I told you, fibroid में pseudocapsule होता है, and this pseudocapsule has all the blood vessels. That means image A is an image of a fibroid, right? Compare this image with image B. Image B में जो structure दिख रहा है वो बहुत smooth है. It is pink in color and there are no surface vessels. That means image B is the image of a polyp, right? Now, in case of polyp, one more typical image which they give you is, so on ultrasound, sometimes it becomes very difficult to differentiate between a polyp and a fibroid. So in order to differentiate between the two, we switch on the Doppler. Now, as I told you, in case of fibroid, the blood vessels are present in the pseudocapsule. So blood vessel should be present around the fibroid. In case of polyp, a single blood vessel comes up till the center of the up till the center of the polyp. Do you see? A single blood vessel coming up till the center of the polyp. This over here is the polyp. And a single blood vessel is coming up till the center of the growth. And this is what is called as feeder vessel sign. So on ultrasound, what I'm getting is a hyperechoic mass, right, which has a narrow base, and I can see a single blood vessel coming up till its center, which is called as feeder vessel sign or a feeding vessel sign. The investigation of choice for polyp is hysteroscopy, and the management of choice for a polyp is hysteroscopic polypectomy, right? Now, if I ask you that a patient of adenomyosis, I give you that specimen of adenomyosis, and I ask you what is the first investigation which you are going to do in a case of adenomyosis. Now, because a patient of adenomyosis is coming to you as AUB, she's coming to you with menorrhagia. That's the most common complaint, right? So, the first investigation whenever a female comes to you with AUB is urine pregnancy test. Do not forget that. Right? Always whenever a female comes to you with AUB. So even if she is a case of polyp, she is coming to you with irregular bleeding. The first investigation which you are going to do will be your urine pregnancy test. Then what was this next investigation? The next investigation which you are going to do is a TVS. Although the investigation of choice for adenomyosis is MRI. Right? Similarly, in a case of polyp, the first investigation which you are going to do will be ultrasound followed by TVS, but then the investigation of choice is hysteroscopy, right? Now, what are the findings which you are going to get when you are doing ultrasound in a patient of adenomyosis? Before that, what are the per-vaginal findings which you are going to get when you do per-vaginal examination in a patient of adenomyosis? In a patient of adenomyosis, uterus will be enlarged, it will be symmetrically enlarged, it will be tender, and it will be soft. Please remember that uterus is enlarged by 10 to 12 weeks pregnant uterus size. It is never more than 12 weeks pregnant uterus size, right? So uterus will be symmetrically enlarged. It will be around 10 to 12 weeks pregnant uterus size, and it is going to be soft and tender. This is called as Halban sign, right? The adnexa are going to be non-tender and there will be no adnexal mass. This is in contrast to the PV findings which you get in endometriosis. In the revision session also I told you that in case of endometriosis, the findings which you get on per vaginal examination are a fixed retroverted uterus. So whenever you get this term fixed retroverted uterus, but uterus is going to be non-tender, it indicates endometriosis. When you are going to check the adnexa, in adnexa mass will be present because of the presence of chocolate cyst, and it will be tenderness could be present. What are the per-vaginal findings which you are going to get in case of polyp? Nothing. Right? Uterus will be normal in size, right? Polyp is a small little mucosal outgrowth. So you are not going to get any typical findings in a case of polyp, right? Now, as I told you, the first investigation which you have to do whenever a patient of adenomyosis comes to you is UPT followed by TVS. On TVS, you are going to get a myometrial cyst. Whenever your question says that there is presence of myometrial cyst, this over here is a cyst which is present in the myometrium. A cyst in the myometrium means there is some fluid in the myometrium, and that means blood is present in the myometrium, and that means there are endometrial glands which are present in the myometrium, because of which bleeding has happened. So whenever you are getting myometrial cyst on ultrasound, it means that it is adenomyosis. You may get a subendometrial cyst or you may get an appearance like this. These are alternate dark and light bands. Now these alternate dark and light bands are called as Venetian blind appearance. Then you may get a salt pepper myometrium. You know, the question may say that you are getting a salt pepper myometrium or a heterogeneous myometrium. Normally myometrium homogeneous होता है. अगर question में दिया है heterogeneous myometrium, it means it is adenomyosis, right? or a poorly defined junctional zone, right? As I told you, the investigation of choice in adenomyosis is MRI. Clear? Now, when you do HSG, when you are doing HSG, in case of polyp or fibroid, you get a filling defect. Right? What do you understand by a filling defect? Filling defect means that the dye is not going in that area. You will get a filling defect. Now, जब भी filling defect मिल रहा है on ultrasound or on HSG, right? Like one filling defect is this, what you are seeing over here. And this is another image which you are where you are getting multiple filling defects, right? Now, whenever you are getting filling defect, first see whether the filling defect is single or multiple. Most of the times when it's a fibroid or a polyp, you are going to get a single filling defect. And look at the margins of the filling defect. If it has smooth margins, then it means it's a fibroid or it's a polyp. In contrast, if you are getting multiple filling defects and these multiple filling defects has irregular outlines, that means it is an Asherman syndrome. So this over here is Asherman syndrome's HSG, right? Please remember, here you will get multiple filling defects and they will have irregular outlines, right? This is what is also called as the moth-eaten appearance. The moth-eaten appearance, right? So this is what you get in case of Asherman syndrome, right? Now look at this typical image over here. What are you seeing over here? In this image, you are seeing that there is a big cyst in the ovary, right? And this cyst is not a clear cyst. It has got a ground glass appearance. So if you are getting a cyst in the ovary with a ground glass appearance, so a cyst in the ovary with a ground glass appearance, or a cyst with homogeneous internal echoes. Homogeneous internal echoes, that means it's a chocolate cyst. So a cyst with homogeneous internal echoes or a ground glass appearance is typical of chocolate cyst, right? So this I have told you what are the pervaginal findings with endometriosis. That is something which I have already told you. The main complaint also I have already told you. Remember, in endometriosis, patient is coming to you with dysmenorrhea, right? So the first investigation which you do in case of endometriosis is also TVS. Although the investigation of choice is laparoscopy, but because patient is coming to you with dysmenorrhea, अब ऐसे पेशेंट को हम इमीडिएटली नहीं कहेंगे कि हम लैप्रोस्कोपी करके देखेंगे, राइट? वी डू टीवीएस बिकॉज वी वांट टू रूल आउट अदर कॉजेज ऑफ डिस्मेनोरिया. Remember, absence of chocolate cyst does not rule out endometriosis, right? Now, this over here is an image where we are seeing that the urethra is being suspended. I just want you to remember that this is what is Bursch-Colpo suspension. In Bursch-Colpo suspension, which is the gold standard management of SUI, stress urinary incontinence, you are suspending the middle urethra, the mid part of urethra. This mid word is important. They try to confuse you by saying proximal urethra or distal urethra. No, it is the mid urethra which is suspended, and it is suspended to Cooper's ligament, right? So it is being suspended to Cooper's ligament. So this needle A is showing you Bursch-Colpo suspension. It is an abdominal surgery, right? It is the gold standard surgery for SUI, but it is abdominal surgery. In contrast, these images which you are seeing, right, in this it is the distal part of urethra. It is the distal part of urethra which is being suspended, and it is a daycare surgery, and these surgeries are TOT and TVT. In TOT, you are passing the suspension ribbons through the obturator foramen. In TVT, you are passing it through the retropubic space. Now, because in TVT you pass these suspensions through the retropubic space, that is the space of Retzius. That is why there are increased chances of injuring the blood vessels, the plexus which is present in the space of Retzius, or there are chances of injuring the bladder. That is why if I have to choose between these two surgeries, we are going to choose TOT over TVT. So remember, SUI में केवल इतना याद रखना है that the most commonly performed surgery is TOT followed by TVT. Gold standard surgery is Bursch-Colpo suspension, right? TOT and TVT में it is the distal urethra which is suspended. TOT and TVT are daycare surgeries and they are vaginal surgeries. Bursch-Colpo suspension is an abdominal surgery. Clear to all of you? Yes? Just quickly write in the chat box if you are understanding, because I am going a little fast, keeping in mind that you have exams just around the corner and this is just a revision class, right? So in the chat box, just show me a thumbs up if you are understanding. Okay, great. Now, what is this instrument which you are seeing over here? Very commonly asked image and instrument. So this is a Leach-Wilkinson cannula. How are you going to identify it? You are going to identify it with its proximal end. So it has a funnel-shaped proximal end and there are serrations which are present. So this is a Leach-Wilkinson cannula. A Leach-Wilkinson cannula is used for doing HSG. When should you do HSG? HSG should be done in the pre-ovulatory phase, that is between day 7 to day 10. The dye which is used in HSG is an iodinated dye, that is urographin. And please remember, HSG is the investigation of choice for tubal patency, right? Then this is a normal HSG. Over here you can see that the dye was passed and this dye has come out through the narrow fallopian tubes and you can also see the spillage of the dye. So this is a normal HSG showing patent tubes. Clear to all of you? Yes? Now, what is this over here? So, although HSG is investigation of choice, but it is not the gold standard for tubal patency. The gold standard investigation for tubal patency is laparoscopic chromoperturbation. In laparoscopic chromoperturbation through vagina with the help of a cannula, I am going to pass a dye, and with the help of laparoscope, I am going to see whether the dye is coming out or not. So this blue colored dye, you are seeing that a laparoscope is inserted and you can see a blue colored dye there. That means it is an image showing laparoscopic chromoperturbation. Now, the dye which is used in laparoscopic chromoperturbation is indigo carmine dye, and if that is not available in the options, then methylene blue dye. So you may use either methylene blue or indigo carmine dye for doing laparoscopic chromoperturbation, right? Now, when I am passing the dye on HSG, it could be that I am getting an image like this. What is this image showing you? This image is showing you that the dye, this is the Leach-Wilkinson cannula. And through this Leach-Wilkinson cannula, the dye was passed. The dye has gone up till the cornual end of the uterus, but the dye has not gone any further. That means there is a bilateral cornual block. Now, if they show you this image and they ask you what is the most common cause of this kind of HSG, the most common cause of a bilateral cornual block is physiological spasm. Right? But the most common pathological cause, this is not a unicornuate uterus. यूनिकॉर्नुएट यूट्रस होता तो एक साइड पे फेलोपियन ट्यूब दिखाई देती. यहाँ पे you are seeing that the dye has gone inside and no fallopian tube is visible on either side, right? So this is a bilateral cornual block. Now, the most common pathological cause for bilateral cornual block is genital TB. Now, if they ask you, show you this image and they ask you what is the next step? Next step is hysteroscopy plus laparoscopy. That means I am going to do a laparoscopic chromoperturbation and hysteroscopic cannulation. Hysteroscopic cannulation का मतलब है I'm going to take a guide wire and I'm going to pass it via vagina into the tubes so that whatever blockage is there, it get relieved, and then I'm going to do a laparoscopic chromoperturbation. So hysteroscopy plus laparoscopy is the next step, right? Now, what is this image showing you over here? Again, this is an HSG image. What is it showing? This was asked in one of your NEET exams. This image is showing that the tubes are dilated and the dye is not spilling out. I cannot see the dye coming out from the tubes. The dye has gone into the tubes. The tubes are dilated, but the dye is not coming out. That means it's a bilateral distal block, right? Bilateral distal block. So this is hydrosalpinx along with bilateral distal block. Whenever you are getting hydrosalpinx, what does that indicate? That indicates that the disease is severe and it has the worst reproductive outcome. Now, everything about how to manage a bilateral distal block, how to manage a hydrosalpinx, I have already discussed with you in the PYQs and also in the revision session, right? So it is there on YouTube, you can check it, right? Now, also I have discussed with you how to identify HSG images. Now, as I told you, whenever you are getting HSG images related to congenital malformations, the first thing which you have to see is the number of fallopian tube. If the number of fallopian tube is 1 and you are getting a banana-shaped uterus, then that means it's a unicornuate uterus. So if you are getting, see over here, do you see that a thin fallopian tube over here like this? I'm erasing so that you can see it again, right? So there is a thin fallopian tube which I can see. That's a single fallopian tube and it's a banana shaped uterus. So this is what is your unicornuate uterus. Clear to all of you? Yes. Then, in a didelphic uterus, what do you get? In a didelphic uterus, you get 2 vaginas. So, whenever you are getting a congenital malformation where you are getting 2 vaginas, so do you see, I will need 2 Leach-Wilkinson cannulas for this kind of a uterus. This is a didelphic uterus. So, whenever there are 2 vaginas present, that indicates didelphic uterus. So, in the images, either they can give you 2 vaginas like this, either they can show you an image like this, or they may show you a vaginal septum like this. Any of these images, if they show you, it means it's a didelphic uterus. Uterus didelphus, right? Now, because in uterus didelphus, there are two vaginas, so you will need two Leach-Wilkinson cannulas to instill the dye. That is why if you get an HSG image like this, where you are getting two Leach-Wilkinson cannulas, whenever you are getting two Leach-Wilkinson cannulas, it has to be a didelphus uterus. Clear to all of you? So whenever you are getting two Leach-Wilkinson cannulas, it has to be a didelphic uterus. Now understand the difference between bicornuate uterus and didelphic uterus. In didelphic uterus, there are two vaginas. In bicornuate uterus, there is a single vagina, right? Do you see a single vagina, right? And you may get one or two cervix, right? If you are getting a single cervix, that is unicollis. If you are getting two cervix, that is bicollis. And always uterus will be two. Clear to all of you? So whenever you are getting a single vagina with either one cervix or two cervix, that's a bicornuate uterus. I want you to notice that in didelphic uterus also the fundus is divided, and in bicornuate uterus also the fundus is divided, right? Compare this to a septate uterus. In a septate uterus, the fundus of the uterus is normal. Fundus is normal. Over here also I am getting one vagina. I am getting two cervix. I am getting two uterus. Depending upon the septa kitna complete septa hai, incomplete septa hai, you may get single cervix, you may get two cervix, right? So a specimen of septate uterus and specimen of bicornuate uterus are very difficult to differentiate. The only feature which you can help them in differentiating them is this fundus. अगर image में fundus normal दिख रहा है, that means it's a septate uterus. If fundus of the uterus is divided, that means it's a bicornuate uterus. Right? Clear? Now please understand this image over here. In this image over here, this is a single vagina. Here is a single cervix and two uterus. अब single vagina, single cervix, two uterus, septate uterus में भी हो सकता है, bicornuate में भी हो सकता है. How am I going to know? It is through this fundus. Because the fundus over here is normal, I am going to say it is septate uterus. Right? Clear to all of you? So I have put images of septate, bicornuate and didelphus uterus together for you so that you can compare and you don't make a mistake when you are trying to identify them in any of the exams which you are sitting for. Right? Now, then comes HSG image. On HSG, how do you differentiate between bicornuate and septate? So always a thumb rule. सबसे पहले HSG में देखो कितने फेलोपियन ट्यूब हैं. 2 फेलोपियन ट्यूब हैं तो यूनिकॉर्नुएट रूल्ड आउट. सिंगल लीच विल्किंसन कैन्युला है तो डायडेल्फस रूल्ड आउट. नाउ आई हैव टू नो वेदर इट इज bicornuate or whether it is septate. So I just have to look at this angle which is present between the horns. If the angle between the horns is obtuse, it is bicornuate uterus. If the angles between the horns is acute, it is septate uterus. Clear to all of you? Yes? Okay. So all these images are important. Then comes another important image which they give you, and that is the image of a Bartholin cyst. Now, as I have told you so many times that Bartholin cyst, it is present between, it will be seen between labia majora and minora, and it will be present on the posterolateral side, right? Now, Bartholin cyst, when they are going to show you, they are going to ask you the management of Bartholin cyst. So over here and also in the PDF, I have given you an updated management of Bartholin cyst. Please remember, if Bartholin cyst is asymptomatic and it is less than 3 centimeters, then no treatment is needed. If it is asymptomatic but it is more than equal to 3 centimeters, then in that case, the earlier answer was marsupialization. Now the answer is incision and drainage with or without placement of a word catheter. Only if they are saying recurrent Bartholin cyst, then the answer is marsupialization. For Bartholin abscess of any size, the answer is incision and drainage. And that reminds me that whenever I have to give you any update, I give it on my Instagram channel. So if you have not yet subscribed to my Instagram channel, please go and subscribe so that you can get whatever updates I want to give you for your exams. Also, I want you to subscribe to my YouTube channel also, bachcho. So if you are liking my lectures, that's the only thing which you are going to do for me. Subscribe to my YouTube channel. Now, this cyst over here, this cyst which you are getting over here is on the wall of vagina. It's on the anterolateral wall of vagina. So the cyst which is present on the wall of vagina is a Gartner's cyst. Bartholin cyst is present in the vestibule, or it is present between labia majora and labia minora. Now this cyst which you are seeing, see this over here is urethra. This is urethra. I am erasing so that you can see properly. Right, the opening is urethra. And this cyst over here is present just above or just on the sides of the urethra. So this is a paraurethral cyst. Right? Now if they ask you which is the most common cyst which is seen in vagina, most common cyst of vagina, please do not answer it as Bartholin cyst. The most common cyst in vagina are inclusion cysts. Right? The next important image are images related to permanent methods of sterilization. As far as image of a female condom is concerned, male condom is concerned, I'm sure you know everything about these images. And also I have discussed them in the PYQ session of neetpg and also in the PYQ session of fmges. Right? Now, this over here is a Fallop ring applicator. Many times this question has been asked, and it is used for laparoscopic tubal ligation. Please remember that the most common method of female sterilization most common method of female sterilization is laparoscopic tubal ligation. But if they ask you which is the most common method of female sterilization in the postpartum period, then it is mini laparotomy. Because laparoscopy cannot be done in the postpartum period, laparoscopy is only done as an interval method of sterilization. It means it can be done only after 6 weeks after delivery. Right? Then this over here is a Pomeroy's technique for mini laparotomy. In a Pomeroy's technique, you are going to make a loop and you are going to ligate the loop with a single ligature, and then you are going to cut the loop. This is Pomeroy's method. This instrument, the instrument with which you are holding the tube, is a Babcock's forceps. Right? Then this is Parkland technique. In Parkland technique, in the mesosalpinx, you are going to make a window. Then you are going to put a double ligature and then you are going to cut the tube, right? So you are doing a double ligature, you are making a window in the mesosalpinx and then you are cutting the tube. That is what is Parkland technique, right? Now, this is Irving's method. In Irving's method, what we are going to do, again, we are going to do a double ligation. And after we have cut the tube, after double ligation, so once you are going to do a double ligation like this, right? Then you are going to cut this part of the tube. The middle part of the tube will be cut. Now this proximal end of the tube, you are going to suture, you are going to make an incision in the myometrium and you are going to stitch it to the myometrium. The distal end, you are going to just suture and put it there only, but the proximal end will be buried in the myometrium. So in Irving's method, it is the proximal end which is buried to the myometrium. In case of Uchida method, what you are going to do is, again in Uchida method, you are going to do a double ligation. The proximal end will be left like this. It is the distal end which you are going to tie, right? So proximal and distal end may say in Irving's method, it's the proximal end which comes on to the myometrium. You make an incision on the myometrium and you stitch it there. In Uchida method, you are going to first do hydrodissection so that there is the entire serosa swells up. Then you are going to do a double ligature. You are going to cut the tube and the proximal end will be left like this only. It retracts, whereas the distal end is stitched along to the serosa, right? So Irving and Uchida may sometimes you get confused. Parkland is very simple. Pomeroy's is very simple to recognize. It's Irving and Uchida where you do a confusion, right? Now, these are the instruments which are needed for non-scalpel vasectomy. In a non-scalpel vasectomy, you need a sharp dissecting forceps. Now, why am I calling it a sharp dissecting forceps? I am calling this as a forceps and this is not a scissors because it has a ratchet lock. Forceps will always have locks. Scissors will not have those locks. There are just two forceps which don't have any lock. So this is a sharp dissecting forceps. And this over here, ring-like clamp. So this is a ringed clamp. Now please understand, forceps will always have a ratchet lock except for two forceps. What are the two forceps? So all those who attended my GSOC classes in Bhatia, all those who have attended Marrow, you should tell me what are the two forceps where there are no locks. Name the forceps which don't have a lock. Tell me. Quickly. What are the two forceps which don't have a lock? Lakshmi, very good. You have told me one. Ovum forceps. Yes, Yoshiga ovum forceps. That's done. Now tell me the second one. Which other forceps doesn't have a lock? Ovum ho gaya. Now tell me the second forceps which doesn't have a lock. None of you will be able to tell me. All of you are just stuck to ovum. Which is the second one? Chittel's forceps. I am not talking about the instruments used in your nasal or ENT surgeries. I am talking about abdominal surgeries, about gynae surgeries, right? So it's a Chittel's forceps. With the help of Chittel's forceps, you pick up instruments, right, during surgery. So these are images which are showing, which are being used for non-scalpel vasectomy. As the name suggests, we are not going to use any scalpel. We are just going to puncture, give local anesthesia, puncture the skin over the vas deferens with the help of dissecting forceps, and with the help of ringed clamp, we are going to bring the vas deferens out and we are going to ligate and cut. Now, another very important thing is that after additional backup should be used for how many days after non-scalpel vasectomy. So an additional backup method should be used for 3 months, that is for 15 to 20 ejaculates, and then you should do a semen analysis. Right, when you are getting azoospermia, then backup method is not needed. The failure rate for vasectomy is 0.1%, right? Now, a few images related to ovarian cancers. This over here is a clear cyst, a uniloculated cyst, which is filled with clear or serous fluid, and this is a serous cyst adenoma. A serous cyst adenoma is mostly bilateral, and the malignancy which occurs whenever serous cyst adenoma becomes malignant is serous cyst adenocarcinoma, right? Now, remember that for epithelial tumors, in epithelial tumors, the most common variety is serous cyst variety. So serous cyst adenocarcinoma is the most common ovarian malignancy to be seen. The tumor marker for epithelial cell tumors is CA125, and on histopathological examination you get a sarcoma body. This over here is a multiloculated cyst which is filled with mucinous material. It has got a honeycomb appearance. This is a mucinous cyst adenoma. Mucinous cyst adenoma are mostly unilateral, and when they are going to become malignant, they result in mucinous cyst adenocarcinoma. For mucinous cyst adenocarcinoma, the tumor markers are CEA and CA19-9. Please remember, whether it is mucinous cyst adenoma or mucinous cyst adenocarcinoma, they can lead to pseudomyxoma peritoni, where the peritoneum is filled with a gelatinous material, and this has got a very bad prognosis. Now, if they ask you, pseudomyxoma peritoni is most commonly seen with. So, pseudomyxoma peritoni is most commonly seen with appendix cancer. Clear? Then these images are images related to dermoid cyst. In a dermoid cyst, you are going to get teeth, hair-like projections, and all of them will arise from a protuberance which is called as your Rokitansky protuberance. On ultrasound, mostly the cyst is going to be anechoic, it is going to be black in color, but on one side you are going to get a white area, and that is what is Rokitansky protuberance, right? So in a dermoid cyst on HSG, you can get a Rokitansky protuberance. The other keywords which you may get when they are talking to you about dermoid is tip of iceberg appearance or dot and dash appearance, right? So remember, a dermoid cyst is the most common ovarian tumor in reproductive age. It is the most common ovarian tumor in a pregnant female. Dermoid cysts are mostly unilateral, but they may be bilateral in 10% cases. It has got all three components of germ cell layers, but the most common component is ectoderm. Now, a dermoid cyst के कितने % chances होते हैं malignancy के? That's also very important question. 0.2 to 2% chances, right? And most commonly, the site where the malignancy is going to happen will be Rokitansky protuberance, and the most common malignancy will be squamous cell carcinoma, right? Then, if you are getting a fleshy, solid, lobulated, tan color ovarian tumor, right? So, a tan color, fleshy, lobulated ovarian tumor, that means it's a dysgerminoma. On histopathological finding, you are going to get nests of cells which are separated by a fibrous tissue. And this septa, that will be separated by a fibrous septa, and this septa is infiltrated by lymphocytes. So if you are getting nests of cells with a fibrous septa in between, that means you are looking at the histopathological examination finding of dysgerminoma. This is an image which has been asked in your exams. This is an image which has been asked in your exams. This image has been asked in your exams. This image has been asked in your exams. Now, related to dysgerminoma is very important when they ask you tumor markers, and all of you remember that the most common tumor marker or the main tumor marker for dysgerminoma is LDH. But these days, the examiners are also very, very intelligent. They are never going to ask you the main tumor marker. They are going to give you a set of tumor markers and they are going to say that all of the following are increased in dysgerminoma except. Now, all of you know that dysgerminoma is the most common malignant ovarian tumor which occurs in dysgenetic gonads, right? तो अगर dysgenetic gonad है किसी मेल के पास, तो will that male be an alpha male? No. So dysgenetic gonads cannot be alpha males. In other words, alpha. राइट, सो डिसजेनेटिक गोनाड्स या डिसजर्मिनोमा में अल्फा वाला ट्यूमर मार्कर नहीं मिलेगा. सो यू द मेन ट्यूमर मार्कर इज LDH. You may get placental alkaline phosphatase HCG, but you will never get alpha fetoprotein in dysgerminoma. So just remember this कि डिसजर्मिनोमा यानी कि डिसजेनेटिक गोनाड्स में अल्फा मेल्स में डिसजेनेटिक गोनाड्स नहीं होते. So alpha fetoprotein is never seen in dysgerminoma, right? That is how I remember it as. So if they are going to give you a list of tumor markers and they are going to say all of the following tumor markers are raised in dysgerminoma except में alpha fetoprotein, right? Now this over here, what you are seeing, it is appearing like a glomerulus, right? So what I am seeing over here is a central capillary. I am seeing a central capillary over here. A central capillary. This central capillary is surrounded by a group of cells, and then further this group of cells is surrounded by a cystic space, right? This is what is Schiller-Duval body. Schiller-Duval body is seen in yolk sac tumor or endodermal sinus tumor, right? Clear? Now, yolk sac tumor is a germ cell tumor which is 100% unilateral. Now, all of you remember that you are alpha males, right? So, since you are alpha males, तो yolk sac tumor में alpha fetoprotein मिलेगा. That's the main tumor marker in yolk sac tumor, right? अब अगर आप alpha male हो तो आप में HCG का क्या काम? What's the use of HCG in your body, right? So they will never have HCG. So yolk sac tumor में the main tumor marker is alpha fetoprotein. LDH can be seen, but one tumor marker which is never seen in yolk sac tumor is HCG, right? So again I'm telling you, dysgerminoma में dysgenetic gonads में never seen is alpha fetoprotein. Yolk sac tumor में you are an alpha male, so you will have alpha fetoprotein, but you will not have HCG. Clear to all of you? Yes? Now, this over here, it is appearing as if a lot of follicles are being seen. So, if you are getting cells which are appearing like follicles, and when you are going to look closely, these cells are going to have coffee bean nuclei, right? So, this is what is a Cal-Exner body. Cal-Exner body is seen in case of granulosa cell tumor. Granulosa cell tumor is an feminizing ovarian tumor, and all of you know कि granulosa cells release करते हैं estrogen, granulosa cells release करते हैं inhibin, and the preantral follicles, the granulosa cells also release anti-Mullerian hormone. So जितने small growing follicles होते हैं, preantral follicles होते हैं, उनका granulosa cell also releases anti-Mullerian hormone. So the tumor marker for granulosa cell tumor are inhibin and anti-Mullerian hormone, right? Now, in this image, I am getting an image which is looking so similar to HPV infection, right? What I am seeing is mucin filled cells and all the nuclei are pushed towards the periphery. This is signet ring cells. It is due to presence of mucin in cytoplasm, and this is seen in Krukenberg tumor. Krukenberg tumor are secondary tumors of the ovary. They are metastatic tumors of the ovary. The most common site for primary tumor is the stomach, and from stomach via retrograde lymphatics, the metastasis comes to the ovary, right? So these are all the important images which I wanted to discuss with you before you give your exams. I may not be seeing you again, so I am also going to take this time to wish you all the best. Bacho, you have really worked hard. This is your dream to get a seat in neetpg, to get a good rank in neetpg. So at this point of time, I don't want any of you to be nervous. I don't want any of you to be anxious. Some anxiety is okay. But if that anxiety is leading to you a state where you are going to say that no, main to exam de hi nahi sakta, I cannot give the exam, that's wrong, right? Remember, everyone is sailing in the same boat, and for every one of you at this point of time, you are going to feel as if I'm forgetting everything. How am I going to remember? How am I going to remember? But then when you are going to give your exams, you are automatically going to remember everything, right? Now, in these last few days, please concentrate only on PYQs and the topics from which PYQs came. Just in case you have made any 20th notebook, then please revise your 20th notebook. Do not get worried about uncommon topics. Everything which is common, your 80% paper is going to come from common topics, from common areas, right? So not to worry at all. I'm going to see you all on the other side. And once you've written your paper, do message me, send a direct message to me on my Instagram handle and let me know how was your OBGY paper. Now, someone was asking me about the missed pills. I will take up this topic on Instagram. So I'll make a small video and I'll put it there so that you understand how do you deal with missed pills, right? So all the best. How to differentiate between testicular and obstructive causes of infertility on the basis of FSH. Very simple. You will answer the question yourself. You people know physiology much more than I know. This over here is hypothalamus. This is pituitary. This is testes. Right? Hypothalamus releases GnRH in males. It is going to release FSH. Pituitary releases FSH and LH. From the testes, the Sertoli cells are going to produce inhibin. Inhibin has a negative feedback on FSH. Leydig cells produce testosterone. Testosterone has a negative feedback on LH and FSH and GnRH. So basically it has a negative effect on GnRH. So it decreases both LH and FSH. Now if there is testicular failure, like you get in case of Klinefelter's syndrome or you get in case of mumps orchitis, what is going to happen? There will be no testosterone, there will be no inhibin. If there will be no testosterone, no inhibin, what will happen to the levels of FSH? They will increase because the negative feedback on FSH is lost, right? Now, obstructive causes means that this entire path is normal. The hypothalamus is normal, pituitary is normal, testes is normal. There is an obstruction in the passage of sperms. Now, if there is an obstruction in the passage of sperms, the levels of FSH are going to be normal, right? So this is how you differentiate between testicular and obstructive azoospermia, right? This PDF is available on my Telegram channel. I uploaded it in the morning only. You want to see the slide of cystadenoma and serous cystadenoma and mucinous cystadenoma? Copy it. Briefly about 21 hydroxylase, 11p, 457 hydroxy. Hi. This is not in brief. This is a lot in detail. I think I have taught this topic in the revision session which I took for you. As far as I remember, in the revision session which I have taken for you, I have told you about 21 alpha hydroxylase deficiency, 11 beta deficiency, 17 deficiencies, P450 deficiencies. Right? Please watch that video, the revision video. It was uploaded around 10 days back and it has got all details. If that hasn't got the details, then the PYQ session of neetpg definitely has details. In either of these two videos, I have done this topic. Vignesh, everything about missed pill actually I have discussed in the previous year क्योंकि ये question NEET में आया था. So in the previous year PYQs, which is there on the YouTube channel, that video is there on my YouTube channel. I have discussed this topic. So please go and watch the PYQ video. You will find this topic there. Thank you, Diksha. Diksha is telling me that I have taught congenital adrenal hyperplasia in revision video. Okay. My Telegram channel is wait, just let me check the name. It is OBG by Sakshi Arora Hans, all in caps. OBG by Sakshi Arora Hans, everything in caps. Okay. So all the best, all of you. Cancer cervix mein, how can I tell you in short? Cancer cervix is a big topic. It is there, beta, it is there. The congenital adrenal hyperplasia is definitely there in one of the revision videos. Right? Okay. Thank you, all of you, for attending this session and also for appreciating all my sessions and giving them so generous views. Thank you all.